Our next panel is beginning now. Reimbursement Strategies featuring Stephen Bolsevich, Jason Furman, Ray Tivierge, moderated by Julie Radovi.
They did my name pretty good.
Well, thank you all very much for joining us. We have a couple people trickling in. My name is Julie Radovi, and I am your moderator for this session. We appreciate you guys being here. We know it is the last session of 3 really great days that we've had. The panel discussions have been amazing, great knowledge coming out of this, and I know personally I've really enjoyed listening to all of the sessions. One of the things that I was thinking about as I listened to the sessions, though, is that there is a commonality here of change. And a lot of what we're going to talk about today, we have heard throughout the last couple of days. And it's a reinforcement of what we really need to do as people that are invested in this space in skilled nursing facilities. And something that Rick actually said last night at his keynote speech of embracing that change was really something that I was listening to and thinking, this is exactly what we're doing. We are still in this and really embracing this change. So today, for this session, what we're going to talk about is building that proper reimbursement strategy while managing those changes on a guideline and policy side. So as an industry, we're used to change. I'm going to age myself. I was an AIT during the late 90s when PBS hit, and I think we didn't know what to do and how to do it, but we did it. And the big difference today is that these changes are constant and always here. So my background, I've worked in post-acute for 27 plus years. I've worked on the payer side and the provider side, building reimbursement models, different alternative models, and working with providers to connect with those payers. And I have the pleasure of being joined by 3 gentlemen here who I'm going to allow to kind of introduce themselves and give you guys a little bit of background on who they are and what they do. Jason?
Good. So good afternoon, or still good morning. My name is Jason Furman. I'm the founder, CEO, and president of LTC ACO. My background is managed care, so don't shoot me. I spent 20 years doing that and was really brought on board a number of years ago by Genesis Healthcare to help move the company from a fee-for-service environment to a value-based environment. And I soon hijacked a physician group we had and put them into the Medicare Shared Savings Program, which now cares for over 18,000 people, managing about $600 million worth of risk, in a program that's very much like an ISNP, but on a fee-for-service platform. And it's not just within Genesis. They're actually one of our smallest customers, but it is nationwide in about 36 states and serving and partnering with about 2,500 physicians and nurse practitioners.
Hello, everybody. Thank you for sticking around with us this afternoon, or this morning, I guess. My name is Ray Tivierge. I have been in the post-acute care business all of my career, 30 plus years. I started working as an administrator and progressed from there in all various aspects of regional and divisional and corporate structure. Most recently, I served as the Chief Strategy Officer for Sava Senior Care, and I am currently working as a consultant both in the sector and outside the sector, applying some of those leadership learnings to other places.
Good morning. I'm Dr. Steve Bislovich. I'm the original co-founder and CEO of Patient Pattern, a company that helped to build technologies to manage patient risk and help value-based care organizations like ISNPs, ACO, ACO REACH, PACE programs really function from a technology perspective. Our company was acquired by Point Click Care earlier this year, and so my new role is to oversee all the senior care, value-based care initiatives and drive data to a longitudinal record within the Point Click Care infrastructure.
Thank you so much. So when we talk about this change, something hit our world that nobody was prepared for, and that is COVID. And we are in the top industry that was affected by this. Healthcare was affected more than any other industry, and skilled nursing facilities was the top of the top. It affected the way that we take care of our residents, staffing, occupancy, how care is actually delivered. And as we unwind from that, we're dealing with inflation costs, labor costs, Medicaid rate changes, Medicare Advantage penetration, and those reimbursement model changes that are coming into the facilities and coming into the space. And while you're managing all those changes, trying to maximize your reimbursement, but also ensure that your quality of care to your residents stays intact. And what we're going to talk about today in our short time together is really focus on some of those different alternative reimbursement models and how it can be maximized to really make it work for the facility and really blend and embrace that change. So our first question is really to kind of level set us a bit. And we're going to look at some of the different types of alternative plans that are out there. When we talk about reimbursement strategy in long-term care, there are, CMMI has different innovations that are coming out, different models, and they're coming out and they're new. And then you've got things like institutional special needs plans, ISNPs, that have been around for 20 plus years. So Jason, why don't you start us off here? And can you give us an overview of the different reimbursement models that are out in the market today?
Sure, I'll do my best. You reference ISNPs, and while technically ISNPs have been around for 20 years, they were a demonstration before that for another 25 years. So United Healthcare, Optum being the one that has been in it now for close to 47 years, is the largest. It took them a lot of time to get to 75,000 members. And so that's not, in the managed care world, a very scaled environment. So there are issues. Scaling an ISNP, it is an insurance product, does require a lot of capital, and so there are differences. There are challenges there. You also have the Medicare Shared Savings Program, which is really centered around physicians, and we use the Shared Savings Program centered around physicians that are caring for long-term care residents and sharing the savings that we generate with both the physicians and the skilled nursing facilities. You have ACO REACH that's come out that is driving a lot of change in the marketplace. But keep in mind, and this is one of the things that I really need to emphasize, none of these programs are designed for skilled nursing facility operators. None of them. CMS doesn't want to hear about it. They got rid of the BPCI program because they thought there was bias in the selection process. So they have yet to buy into all this. So the view is now, how do you acclimate yourself? How do you align yourself with the best value-based program out there? So now you have these REACH programs. People have jumped into REACH, or entities jumped into REACH because there's certain prepaid cash flow implications. We'll see how long that lasts. It's still a demonstration program. But keep in mind that with almost, out of the 456 ACOs that were in a program last year, 455 were not focused on institutional-based population, and all 455 made money off the backs of skilled nursing facility operators. So there's just it's a tenuous place to be, but it's an important place to be, and there are opportunities to gain traction in that area.
Excellent, thank you. So in looking at those models, Ray, what are your thoughts, and can you provide us some examples of, in your position as an operator, how this has worked well? Is there a model out there that you can kind of give us an example of when it really does work well in the SNFs?
Well, to just piggyback on something Jason just said, none of these models, with the exception of one, are really geared for skilled nursing facilities. So they are not designed with nursing home operations in mind. And so, as such, I think when you look at the success or failure of these models in the skilled nursing environment, it really boils down to how prepared the center is to drive change according to the rules of engagement of their model. So for me, the experience that I had, and this is not a commercial for my friend Jason, who happens to be in charge of LTC ACO, but that's the one ACO out there that is actually geared around going after the physician that has a patient panel in the skilled nursing facility. And as such, you're working with your doctors to align care incentives with your payer. And you're not doing it directly with your payer, but you're doing it to influence your payer, right? And so those models, that model to me is setting an example, and I'm trusting that as we go through time here and the value-based care initiatives become more long-term care focused, that we're going to see more opportunities to really achieve that alignment, because that is the key. The ability to understand the levers that need to be pulled in order to optimize the reimbursement, and then have the proper language and the proper mechanisms to teach your nursing staff, who are focused on other things, to teach them a little bit about what they need to do differently in order to accommodate or to achieve the goals of the program, and then bring in your physicians as well and align them with those practices. That to me is the key to success, right? The alignment. And so I think we've got a long way to go in the value-based care world to try to align with skilled nursing home realities.
Excellent, thank you. And when the model does work well in the facility, how does that change the medical practices of the facility?
Well, we tend to talk about reimbursement and, in particular, value-based care models or ACOs or LTC ACO, all of them, we tend to talk about them as reimbursement strategies. But the whole reason they exist is because the payer or the government is trying to influence behavior change at the bedside, trying to influence resource consumption, trying to resource the way patients are cared for so that we optimize care. Most of them have some level of quality built into the reimbursement structure, but also at the same time, optimize resource utilization. And so when they're done well, I believe, and this is really a voluntary effort at this point, because most operators look at how can we do it out of necessity. I'm not slamming operators, it's out of necessity. We haven't got time to spend time on things that don't have a direct ROI for us. We just don't. Right. But when and if we do, and we have the ability to sort of look at the program from the perspective of this is an opportunity for us to drive a different level of outcome, with a reward being a financial incentive that's geared around those behaviors, I think, again, back to the idea of alignment, we have the opportunity to really impact the way care is done. Mm-hmm. And we're starting to see this a little bit more with some of the ACOs who are coming in with these third-party care manager focuses, because and that's the intent, is to try to add another layer into the system that will help align some of these care practices. The reality is that'll be best accomplished by the building itself, right? Just like case management, when in the managed care world, is an added layer of burden to the center. These care model supervisors are going to be the same. It's going to be an added layer of reporting, an added layer of documentation that is going to stress an already stressed system. But I think when it is working well, it has the ability to actually achieve a goal of redesigning the way we work together within the system.
And do you mind if I add something into
that? Yeah, absolutely.
I thought that was a great explanation, right? I think there's another, we always look at the world as a three-legged stool. You've got the facilities, you've got the physicians, and you do have the ACO or the value-based provider, whatever. But these physicians are, you have to keep in mind, they're incented, right, based on encounters. And the more things you ask them to do, the less money they make. So unless you can put in place a reimbursement system or a supplemental reimbursement system that helps them help you. It's to Ray's point, it's going to be difficult to lift that ship because it really does take not just an operator's clinical staff, but the physicians that need to be aligned with your objectives to help lift that boat.
Yeah, absolutely. And Steve, you had mentioned something when we all spoke a while back that I would love for you to expand on because I think that it gels well with this conversation. And that is, when a payment system comes into your facility, an alternative model with a patient, whether that patient's coming in for just short-term rehab or actually coming in and being a resident in the long-term care side, something like an IPA. How do you make sure that it stays a benefit to that resident while not becoming a disruptor to your facility?
Well, I think one of the biggest challenges is for operators, for example, is actually to understand who the payer is for every resident that comes in the door. And most of the time, it's not clear. It's very hard to tell if they're participating in a risk-bearing entity of some nature. And so we need better tools to figure out, A, who are they, and how do you manage them? And I think to Jason's earlier point, it is a three-legged stool, but it seems like the incentives outside of a value-based care environment are actually misaligned, right? So the provider has their own incentives for reimbursement and cost management. The practice provider groups are looking at mostly a fee-for-service, volume-driven approach and sort of game to their reimbursement strategy, and the risk-bearing entity, has their own requirements, right? And so that conflict has to go away in order for us to really align our workflows, our approach, and really do the right thing for the patient in a way that manages not only the clinical outcomes, but also manages the coding, for example, right? The coding is very tricky. For a Part A patient that comes in, for example, they might be enrolled in an ISNP or an ACO. The building has to code them for PDPM. That doesn't match the ICD-10 library for an HCC requirement for an ACO, or that HCC library is actually different for an ISNP than an ACO. And so understanding how to code is extremely challenging. It's not something clinicians really understand well. It's very difficult to keep up with it. And then ultimately, they could be seeing, Patsy, and Patsy's part of an ACO, and you have to code in one way. And then John next door is fee-for-service, and you're just coding regular, fee-for-service visits. And then the next resident is actually enrolled in ISIP. So now you need to look at a very different approach to, close gaps and do certain quality measure collections. And at the same time, there are no tools out there that really help all of us collaborate. And so there's a sort of friction in the market, and that needs to evolve. And it actually, goes away when everybody's aligned in one or two value-based care approaches, because then it's much easier to know what to do, who to focus on, and outcomes drive success. If you can't manage the clinical risk of your members at the bedside, you will not be successful regardless of whether you're in ACO, ACO REACH, PACE, ISNP, it doesn't really matter. So as a geriatrician, managing patients is really first and foremost, and then coding everything else is secondary. But ultimately, if we're not assigning the right resources to that particular member based on their risk profile, how can we be successful in a risk-bearing payment mechanism? And so for any provider that's really interested in starting to participate in these alternative models, the first question I would ask yourselves is, how are you doing managing risk today? Can you deliver favorable outcomes in your facilities, in your populations? And if you can, then you really you want to participate in some of these opportunities. But if you're not able to control those outcomes reliably, you're not going to be successful. You could lose your shirt pretty quickly as well. And so that's kind of where the patient care starts tying into the reimbursement strategies, and everybody has to basically be on the same page.
Absolutely. And I think I would love to hear your thoughts and to expand a little bit more on the integration of those systems. How does an operator, or how should an operator ensure that proper tracking and coding? And how is that integrating to systems that are already set in their buildings?
So one of the, we'll say, most unclear areas for an operator is ultimately coding. The way any risk-bearing entity typically gets reimbursed is through a risk adjustment approach, right? So it's a RAF score, risk adjustment factor. That's not typically how the building gets reimbursed. Right. And so ultimately, you now need to code and document very differently and understand how these models work. There's a new model coming out in 24 that's basically made waves in the industry already. You see this impact Optum's laying off hundreds of thousands of individuals, or whatever the number is, but it's really impacting how we approach these models. And so it's really, I think, a technological mountain to climb, because the clinical documentation and the coding needs to support not only what's important for the building, but also what's important for the health plan. And those systems may be very different. What we're seeing today in the market is you have facilities running a particular EHR, and you have practice groups coming in with a multitude of different fragmented solutions, sometimes paper, sometimes different systems. They don't necessarily integrate. And so what you're essentially challenged with is, how do you actually assign compliance mechanisms to those codes to support that documentation in case of an audit? And so if you're managing risk, you have to be able to code, but you also have to be compliant about it, and you have to support it. And if you have multiple systems that aren't integrated, that really aren't longitudinally tracking consistently these codes, you're going to potentially be at risk, and you're going to be writing a nice big check back to CMS or whoever. And so ultimately, that is the biggest challenge, is how do you create integrations in the market with data flow in such a way where you have consistency instead of 17 diabetes codes for the same resident, right? It just doesn't make sense. And so how do we really figure out what is the most accurate one, how do we support it, and how do we maintain consistencies across the continuum of care?
Mm-hmm. And I definitely think that goes back a little bit to, Ray, your point on that staff buy-in and that physician buy-in, right? In my time with Medicare Advantage plans and ISNPs, I always thought that they worked best when everyone in the building really had buy-in, that the staff understood the benefits that the facility was receiving, that the residents were receiving, that they were receiving. So I would think that connection is so important in that space.
I absolutely agree. I think the challenge we have with achieving buy-in, to use your expression, is it really, in order for it to really matter to the frontline staff, it has to be buy-in from the perspective that they value, right? They don't necessarily, a frontline worker doesn't necessarily value the fact that this is a savings opportunity for the nursing home operation, or that the owner of the building engaged in a contract with an entity that they don't understand. So the challenge that I think operators have and supervisors have is to be able to convey the value in terms that mean something to the people that have to have a behavior change in order for the system to work. Mm-hmm. And I don't know that we're necessarily very good at that. I think we do inform. I think leadership does inform the staff when we've made a system change. But I'm not sure that we've taken necessarily the right amount of time to turn it into something that is of value to the CNA or to the nurse who needs to document differently now for things that they feel are just like what they were doing before. Yeah. And the same is true, by the way, with physicians. Because with all due respect to my physician friends, they don't always come into the facility with everybody else's best interests in mind. They're there to do a very specific task. They're there to achieve their own goals. And I don't think it's enough to tell them, this is what I need you to do for me. I think we need to your point, really get the buy-in from the perspective of helping them understand why it's important to the system as a whole, or possibly even why it's important to them personally. And that's where, again, I guess I didn't set out to sit on this panel with a theme, but it does boil down to alignment, right? But not just alignment of the operator or the top guy or top gal's idea, but alignment of all of the behaviors that need to change, and how do we make that happen through our leadership.
Excellent. Thank you. So, along with all of this, and, we've kind of feel like we've kind of said, well, all of these things have to kind of be in line in order for these things to work. On top of that, operators are dealing with constant regulatory change. We've heard it a couple times in the last few days, this new staffing mandates. The SNF proposed rural payment system for 2024 came out about a month ago and said that, CMS is estimating about a 4% net increase of payment, which is good, but we're still dealing with parity adjustments for PDPM. Hopefully 2024 is the last parity adjustment they'll make. And 4% is nice, but it's not big. It's not enough to deal with the staffing mandates and all of the other items. So when we look at that and know that that's happening as we're coming out of PHE and dealing with PDPM being this massive change in how things were being done and all the other things that are out there, if an operator were to choose to work with an innovative model, with an alternative payment model, when comparing to that traditional PDPM system, Jason, what would you say is the biggest advantage?
Well, I'm not an operator, so I'm not going to pretend to be one, and PDPM is something that is pretty complicated, but I think going back to Steve's point, coding is key to PDPM. Coding is key to whether it's Medicare Advantage, whether it's the iSNP under Medicare Advantage, whether it's the EC or REACH or MSSP, is key. So I think that, you begin to get alignment there with respect to making sure, once again, that your physicians are coding properly, that you can support it in your documentation. Typically, the documentation coming from the nursing home is not, while it influences PDPM, does not influence other value-based programs. It is, however, the physician coding that will influence all these other value-based programs. So again, the key to all this, and this is getting back to the alignment issue, right, is getting everybody on the same page, because it does make a difference, not only to an operator's bottom line, but to the ability to collaborate and actually market yourself to value-based programs that you can add value to them, and they're not just taken from you.
Thank you. And Ray, what would you say is the biggest risk associated with going with an alternative model and shifting away from that PDPM?
I think the biggest risk is assuming that it's just a reimbursement strategy, and having it become a problem that ultimately ends up detracting from care because you're getting reimbursed less than what you would have been. It's the biggest obstacle, obviously, for the center in all of this is finding the time to handle this change on top of everything else that's going on in the center, and quite honestly, it's not like handling it and being done, because with turnover the way things go, you're just going to get one round tuned into what you're doing, and it's going to be time to do it again. And so I think the biggest obstacle is thinking of it as somebody else's job, thinking about it as a reimbursement function, and not understanding that the culture of the center needs to really embrace the model. That the model, it needs to be thought of in such a way that it becomes part of how you train staff when you bring them in. It's something that you hire for. It's an intuition, and it's an ability that you build into your core functions over time, and that it becomes grounded in how you work. If you treat it as a reimbursement program, you're going to end up not aligning, and that misalignment is going to cost dollars.
Steve, with technology in mind, and I know that's your sweet spot, how do you reduce that risk? How do you make this easy and make this work for the facility?
You know, I think honestly it's a very exciting time. Number one is by 2030, 100% of all Medicare and Medicaid patients will be in some alternative payment model. And there's not a lot of time for organizations to sort of step up and start either trying things, learning about it. And there's really a spectrum of sort of risk management, right? So you can be sort of, in my mind, on the sort of passive participant side of things versus I'm starting my own health plan, right, spectrum. And most providers are somewhere in between. I personally work with about half of the provider-owned ISNPs in the country, and we see different strategies across different markets. But one thing that's really uniform in terms of a side benefit that a lot of organizations don't realize is that having the alternative payment model creates new, not only incentives, but new avenues to actually have services available to your residents in your buildings that you otherwise could not afford. So for example, a lot of ISNPs have nurse practitioner groups that service the ISNP residents. And what we hear from providers is that, well, I already have this excellent NP that's patient-centered, they're reducing hospitalizations, they're reducing costs, they're helping my short-staffed nurses manage these patients better, and they can offload some of the shortcomings in the facility. Can they also see our other residents? Could they also help us with quality improvement programs? Could they help us with educating our staff? And that kind of environment does impact staffing retention. It does change the perception of the facility to really look at the other residents and really change the dynamics. But without data, you cannot really survive. You cannot understand where to pay attention. And you don't have the time nor the resources to approach everybody the same way. So you have to know who requires more time and attention. And being able to take data across the continuum is something that I'm really excited about, when you can really automatically track a member across any transition. What's really unique is when you start taking on risk, that risk doesn't start and end in your building. It's a longitudinal annual risk that you're basically on the hook for. And ultimately, you need data not only from your building, but you need data from the community, from the hospitals, from the health information exchanges. And you need to be able to support that risk within transitions and really have a team, a care team, care coordination, and care management team that transcends any particular care setting. And that's a fundamental difference for most operators. They don't really always see it that way. They're still kind of focused on the building's the building, and once the patient leaves, the chapter's closed. But in reality, you need to be able to manage that risk. You need data to do it. You need interoperability, and you need systems in place to be able to handle that.
Great, thank you. So we've talked a lot about that alignment process and the back end work that goes with this. And a few weeks ago, I think it was actually mid-August, Skilled Nursing News came out with an article. It was titled, "Medicare Advantage Linked to Less Favorable Outcomes, Reduced Post-Acute Care Use." And they specifically quoted a study that was published by JAMA Health Forum suggesting that Medicare Advantage enrollees reported less functional improvements while using post-acute services. And in the article, it kind of leaned towards prior authorization being a big piece of the issue. However, what I thought was interesting was it also stated that those Medicare Advantage patients had better outcomes with readmissions and successful discharging to the community. So I wanted to bring this up because I know that there's some reputation that kind of comes with, Jason said at the beginning, don't kill me because I managed care, I'm in the same boat. Managed care sometimes has a little bit of a bad reputation because of these types of things. So wanted to kind of just get your comments and your thoughts. Jason, you want to start us off?
Yeah, I mean, I'll be glad to start off. I'm one of the guys that was very concerned when NavaHealth came out and was going to move people along the continuum a lot faster. But the data, as you suggest, show that while the recipients or the beneficiary may not rate their quality of care as high as others, the rehospitalization rate hasn't kicked in. And at the end of the day, that's how folks are measured, from a managed care perspective. That's how you're measured. And so I think it's been positive, but I think the industry needs to embrace that and really understand that and find creative ways to participate in the entire, in as much of the continuum as possible so they can gain the benefit from it. Because without that, it's just money out of the operator's pocket. But there's still a lot to be done and a lot of accountability with that transition of care that really works to enforce the outcomes that you're seeing now.
Ray, your thoughts?
Well, my reaction to that article was that, this is very much still a work in progress. And I feel like, we are looking at a road ahead that is dictating our journey, right? We know by 2030, we're going to be in the game. That doesn't mean that we're all playing the game real well right now. And I feel like there's going to be opportunity for articles that are going to reinforce the fears that a lot of us have around this type of change. And they're likely to find they're likely to find some tidbits where opportunity for improvement exists. And I don't think we should ever lose that focus. We should always be looking for those things that we can improve and bring those statistics and those studies to something that could be, improved upon. But I feel like it's part of the process, right? Anytime there's change, there's going to be somebody somewhere saying, "I told you this wasn't going to work," and I think that they'll find things to reinforce that, right? At the end of the day, what does it matter? We're going down that road, and I feel like the best thing that we can do right now is embrace it, prepare for it, and understand it to the extent that we're not only able to optimize it for ourselves, but we're able to really drive the types of behavior changes out of our people that we need to have in order for it to be successful.
Great, thank you. And Steve, your thoughts?
I think it's important to differentiate general MA from some of the things we're discussing, which is, institutional special needs plans, for example. General MA is, I think, what most providers are afraid of. So the way I look at it is really it's an opportunity, because if you look at the data from ISNPs, for example, which is a subset of MA, designed for this institutional or institutional equivalent population, their outcomes are favorable, right? And Optum, to their credit, has done a great job collecting this data, marketing this data, and showing that having an ISNP program in your building improves clinical outcomes. And I think I see that as well. Honestly, I think the challenge is that, what I think providers are looking at right now is, do you want to be at the table and actually be that plan and take that risk and take the upside, or do you want to be on the menu, right? And so that's really the decision that I think most providers have to make is, either you're going to take that risk and you're going to figure out how to manage that risk well and participate financially in the success, or somebody else will do that for you. And you're not going to have any control. And if General MA comes in and says, you got to discharge this patient sooner, sorry, or we're not even sending them to the SNF anymore, you're at risk. And so you're not avoiding risk by not participating in some of these models or really, taking the reins on that. You're going to be basically, I think, eaten over the course of the next decade. And so to me, it's an opportunity and it's a wake-up call to say, okay, is this really representative? No, it's general MA. I think we know what managed care does. But if you are actually the plan, the building, the clinical group, you can actually do things very differently and successfully and control the entire full capitation of that individual cost. And Jason will probably be the first one to tell you that the benchmarks are really high for this population. And so the threshold for shared savings is actually very impressive, in some cases even better than institutional special needs plans. So there are different models and financial opportunities that I think folks are just not fully aware of yet that they can take advantage of.
Yeah, absolutely. And that was mentioned actually yesterday in the business model panel. I love that being at the table because I think that that's really important to be in the mix. Thank you so much. Well, we are down to about 5 more minutes, and we did want to open up just for any questions that anybody might have that we can potentially answer for you. Anything out there?
Who here is participating in the alternative payment model just by show of hands?
That's a great question.
Anybody willing to share what type of models?
Yeah, I do have a question about sort of this alignment everybody's talking about. Do you think, open to the panel, do you think the hospitals are playing a bigger role getting involved in post-acute care, or are they looking for partners to do that?
That's a great question.
Yeah, I mean, I think from my perspective, they're looking to control the post-acute care dollar. So they're looking to take money out of your pocket. That's the way they're going to save money. That's the easiest, most commoditized way for them to make money. And so, but the trade-off is that if you don't cooperate with them, right, then you're risking your distribution channel. So that's not necessarily alignment. That's a quid pro quo. That's a really big bet. But I wouldn't go as far to say they're trying to align with you and get better outcomes. They're trying to get people through their system, through the DRG system, into a system that's more of a hold system and get them out as fast as possible. And that hurts providers.
Thank you. That was a great question.
Can I add one more
Yeah,
thing before we
please.
end? Because I think it's important. We've talked about different models here, whether it's iSNP, whether it's MSSP, whether it's ACO REACH. It's not a binary or trinary decision. In fact, when you think about it, if you're using iSNP as a basis, the goal is to provide care in place. From a Medicare shared savings program, the goal is to provide care in place. From ACO REACH, it's the same goal. The financing mechanisms may be different, but there's no conflict, right? In an iSNP, you're selling one patient at a time. With any of these other programs, you're getting wholesale patients through your physician partners. And you're only going to get 30% of the people into an iSNP anyway. So you have 70% of your house that's covered by fee-for-service. So why not find an alternative to create value-based programs off of that? And it makes it easier, right, on your nurses and your CNAs not to worry about what insurance or what plan someone's on, but to care for everybody the same way. So it's almost like turning the tables on the care delivery system the way they were 20 years ago, where you care for everybody the same way before all these iSNPs popped up. Now you have iSNPs and MSSP. The tables have been turned. So why not participate the same way? You'll get better outcomes. You'll be able to sell those outcomes to whether it's your Medicare Advantage, your iSNP, or your ACO partners. So I think that's a really important point. This is not a binary decision. Yes. They all work together. They all have the same clinical goals. They all have the same quality goals. They're just different financing mechanisms.
Yeah, absolutely. And you are, as you stated so well, the goal is the same, right? The care of the patient and that quality care that you're trying to provide to that patient. And that's going to then unify that staff and build that buy-in that we're really looking for in that alignment.
Well, I think just to piggyback on the question, if you can drive better outcomes, the hospitals are going to start paying attention, right? And so you need to drive that care delivery because everybody wins. And the issue is, the hospitals are against us, but if you are that quality provider and you can drive risk in a favorable direction, they're all going to run in your direction. And I think that's kind of the ecosystem that value-based care is creating, is everybody's looking at who are my high-quality performers in my markets. And having a value-based care initiative that you're participating in drives that and accelerates your path to providing better outcomes. And I think that's what's going to be the difference between those that are going to be around and those that are going to be eaten by others in the future as well.
Yeah, absolutely.
Yeah.
Shows the value of your center for sure. Well, thank you. Well, we are out of time. We actually knew as a group that we could go down 1,000 rabbit holes with this subject, so I'm pretty impressed that we finished in 45 minutes. But thank you so much for joining us, and we really appreciate it.
Thanks.